Morning, and welcome to the 2022 American Society of Clinical Oncology Annual Meeting. I'm Dr. Julie Graylow. I'm ASCO's Chief Medical Officer and Executive Vice President, and we thank you for joining us here in Chicago, as well as those of you who are online. This year's meeting is expected to bring together more than 40,000 attendees from around the world, both in person and online. We'll hear official attendance numbers during Dr. Everett Vogt's presidential address tomorrow in the opening session, but I can tell you that about 75% of our registrants plan to attend in person, with the remaining online. As the largest clinical cancer research meeting, every year ASCO features important practice-changing research. Research presented at the 2022 ASCO annual meeting demonstrates the progress we're making against cancer. Over the next several days, you'll hear how ASCO is working towards the meeting's theme this year of advancing equitable cancer care through innovation. More than 2,800 abstracts will be presented during the meeting, and an additional 2,400 will be published online. In addition to today's press briefing, there will be 3 more briefings here on site in this room, one each on Saturday, Sunday, and Monday, and they'll all start at 8 a.m. For today's briefing, we've highlighted 2 abstracts providing important new insights into the treatment of mantle cell lymphoma and KRAS wild-type locally advanced or metastatic pancreatic cancer. Unfortunately, one of our presenters, Dr. Chin, has become unavailable at the very last minute, so we will not have a presentation from him at this press briefing. His prepared slides for this briefing, however, will be available to you to download as part of the press packets, and you will be able to see his full presentation, which he has recorded for his session. As I believe you're all aware, the embargo on these 2 abstracts lifted this morning at 7 a.m. Central Time. I'd now like to introduce Dr. Michael Wong from the University of Texas MD Anderson Cancer Center, who will present the findings from an analysis of ibrutinib in combination with bendamustinerituximab and along with rituximab maintenance as first-line treatment for older patients with mantle cell lymphoma. Dr. Wong?
Thank you, Dr. Grillo, for that kind introduction. Thank you for coming. So, ladies and gentlemen, I just keep on advancing, right? So, at this ASCO, I'm very, very excited to present our phase 3 clinical trial. So, this clinical trial, we're presenting at this meeting the primary results of the double-blind, placebo-controlled phase 3 SHINE study in mantle cell lymphoma. So here are my disclosures. So mantle cell lymphoma is a type of non-Hodgkin's lymphoma, accounting about 6% of the whole NHL. So older patients diagnosed with newly diagnosed mantle cell lymphoma are usually treated with chemoimmunotherapies such as R-CHOP therapy, bendamustinerituximab, or VRCAP therapy. And bendamustinerituximab, or BR, has become the most commonly used first-line therapy in this elderly population. Why? Because it has significantly improved the progression-free survival as compared with the R-CHOP therapy and also with a better safety profile. So rituximab maintenance or R maintenance is also a very good addition after BR. With the BR, it has shown to prolong the progression-free survival in 2 independent real-world studies. And BTK inhibitor, ibrutinib, is the first-in-class oral BTK inhibitor that has transformed the care of relapsed mantle cell lymphoma. And it is especially powerful when used at the first relapse. So And also the ibrutinib plus bendamustinerituximab together has been shown in the phase 1b clinical trial to be not only safe but effective at the front line for elderly patients with the mantle cell lymphoma. So with all this information, and we designed the phase 3 SHINE clinical trial 10 years ago. So in this clinical trial, we enrolled patients with a newly diagnosed mantle cell lymphoma at the age of 65 or older. As you can see, in the blue, as shown in blue, the experimental arm or the ibrutinib arm consists of bendamustinerituximab for 6 cycles, followed by arm maintenance plus ibrutinib until progression or intolerance. In contrast, as shown in green, in the placebo arm, we also included bendamustinerituximab for 6 cycles with arm maintenance, but here we used the placebo until progression or intolerance. The primary endpoint was progression-free survival in the ITT population. As you can see from this curve, the primary endpoint of failure, the primary endpoint of progression-free survival was met. So in other words, our SHINE clinical trial is a positive clinical trial because it successfully met the primary endpoint. As you can see, the median progression-free survival was 80.6 months in the ibrutinib arm versus 52.9 months in the placebo arm. The hazard ratio was 0.75, and these data are very statistically significant. As you can see, the two curves separated early, indicating the benefit was achieved early within the first year, and also those benefits remained durable throughout the 7-year follow-up time. So if you put the PFS, instead of months, you put them in years, in the ibrutinib arm is 6.7 years versus 4.4 years in the placebo arm. So there's a significant achievement of a net 2.3-year progression-free survival in favor of the experimental ibrutinib arm. Indeed, this is very meaningful. Imagine a patient is diagnosed with a malignant, life-threatening lymphoma with mantle cell lymphoma, and we use this regimen, we achieved 60.7 years without any disease. And this is truly meaningful and really a remarkable achievement in the field of for those patients. So the safety profile was no surprise. They were within our expectation and consistent with what we're seeing in daily practice about ibrutinib or BR. But please note the most common side effects are neutropenia, and they are about 50% in each arm. The other side effects are, again, within expectations, and with the rash and pneumonia, they are higher in the ibrutinib arm versus the placebo arm. So in conclusion, SHINE is the first phase 3 clinical trial that shown ibrutinib in combination with chemoimmunotherapy is highly effective in elderly patients with a newly diagnosed mantle cell lymphoma. The median progression-free survival of 6.7 years is the highest PFS rate ever reported in this population. And it is very statistically, significantly, and clinically meaningful, and this advantage of 2.3 years. So, so the safety profile, again, is within expectation, consistent with our past data on ibrutinib and bendamustinerituximab. We believe this phase 3 clinical trial set a new benchmark for patients with a newly diagnosed mantle cell lymphoma and the elderly, and for those patients who are not eligible for autologous stem cell transplantation. Thank you for coming. I'm open for questions.
Why don't you have a seat? And